A dentist who told you that you're not a candidate for dental implants probably never treated a case as complex as yours. Maybe you've been told you don't have enough bone, or your case is too complicated, or implants just aren't an option for someone like you. You walked out of that office carrying a label that was never yours to carry. And now you're wondering if a full, fixed, permanent set of teeth is even possible. After performing thousands of full arch cases, I know what a real candidacy assessment looks like. The cases that come to me after being turned away, some of the most instructive I've ever worked on. I want to tell you about the case that changed how I think about it all. My grandfather, 94 years old, advanced bone loss. By the end of one day, he had permanent fixed set of digitally designed custom teeth in his mouth. What that taught me about who is actually a candidate and why the bar for most people believe exists is almost nothing like the real one. We're going to walk through why the not a candidate conversation almost always goes wrong, what a real evaluation actually looks like, and what you can do right now to find out where you actually stand. For a long time, the assumption was simple. If you don't have adequate bone volume in the right locations, implants are off the table. Bone loss meant dentures. End of conversation. That belief came from a real limitation. Older surgical techniques required a specific bone height and width in precise locations, and if the bone wasn't there, the implant couldn't be placed. So practitioners learned to filter patients early. They tell them no before even running a 3D scan. It became habit. It became standard. And patients had no reason to question it because they had no way to see what the practitioner was seeing. Most of those not a candidate conversations are happening without a cone beam CT scan, without three-dimensional imaging, without a surgical plan that accounts for angulation, alternative placement sites, or the anatomy that actually exists under the surface. The decision is being made with a flat x-ray and a quick exam. That's not an evaluation. That's a filter. You were turned away based on what someone could see on the surface. Nobody looked at what was underneath. This matters because candidacy isn't binary. There's a spectrum. And where you land on that spectrum depends almost entirely on the quality of the technology being used and the depth of the training behind the person reading it. Modern 3D imaging shows the full picture of the bone that exists. Angled implant techniques allow placement in locations that older straight placement methods couldn't access. Zygomatic implants reach bone and cheekbones for patients with severe maxillary atrophy. The anatomy that was once considered disqualifying is now, in most cases, workable. The question isn't whether the bone is there. The question is whether the person evaluating you knows how to use what's there. My grandfather was 94 years old. He had significant bone loss. He was the kind of case that, in most offices, would have been handed a denture referral without a second thought. We go to family events and we're going around to a family reunion and he's with all his long relatives and we go around the barbecue and they're all taking out their dentures to eat the corn on the cob in the summer and he's going around and showing his cousins and nieces and nephews all with dentures and wiggling his teeth and say, see, these don't come out. That's how important and how unique it was for someone of his age to have fixed permanent teeth. Anyways, we did the imaging. We planned the surgery with precision. He had his implants placed and his permanent digital teeth delivered in a single day. He's not an outlier. He's what the procedure looks like when done by someone who spent time to master it. When you understand that not a candidate is a clinical opinion and not a medical fact, the entire conversation changes. You stop accepting the first answer. You start asking better questions. You start looking for a second opinion from someone whose entire practice is built around this specific procedure. But understanding that the verdict is wrong is only part of it. You also need to understand why so many practitioners are still giving that verdict in 2026 and what's actually happening inside those offices when they turn patients away. Patients tend to assume that when a dentist says not a candidate, it's a protective judgment. That the practitioner looked at the case, weighed the risks, and concluded that attempting the procedure would cause harm. That belief gives the verdict authority it may not deserve. Dentists are trusted professionals. The assumption of protective intent is reasonable. And most practitioners who turn patients away generally believe they're doing the right thing. They're not lying. They're being honest about what they're capable of delivering. The problem is that they're presenting their capability limit as a patient limit. There's a phrase I come back to often. Don't pigeonhole your patients based on your clinical skill set. If a general dentist has never placed an implant in severely resorbed bone, of course the case looks impossible. If a practitioner has never done same-day arch delivery, of course it seems too aggressive. The ceiling they're describing is their ceiling, not yours. The person who told you that you're not a candidate may have never successfully treated a case as complex as yours. That doesn't make you uncomplicated. It makes them undertrained for your situation. This isn't an indictment of every general practitioner. There are excellent dentists who are exactly right to refer complex full arch cases out. The issue is when the referral never happens, when the conversation ends at not a candidate, instead of not a candidate for what I do here, but let me point you to someone who handles this every day. The standard of care this procedure deserves is a practitioner whose volume in full arch cases is in the thousands, not dozens, who's trained specifically in advanced implant placement, who has the 3D imaging and in-house fabrication, who plans the surgery digitally before touching the patient, and who can manage every phase of the process without sending you somewhere else. That combination is rarer than it should be. When you find it, the conversation about candidacy sounds completely different. In over 2,000 full arch cases, the patterns are clear. Patients with advanced bone loss who were told no elsewhere are completing treatment. Patients with systemic conditions that were used as disqualifiers are sitting in the chair having successful surgeries. The cases I see that were turned away somewhere else aren't the exceptions. They're a substantial portion of who walks through the door when you understand that not a candidate verdict reflects the practitioner's limits more often than your anatomy. You stop carrying that label as an identity. You start carrying it as a data point about one person's assessment. And data points can be tested. So if the verdict is suspect and the skill gap is real, the next question, what does actual candidacy evaluation look like? And how do you know whether the one received was thorough enough to trust? If you're finding this useful, subscribe before you keep watching. Every video in the series goes deeper on the specific questions you need to be asking before you make any decision about your teeth. Hit subscribe now so you don't miss a single one. Think about what your candidacy conversation actually looked like. Was there a 3D cone beam scan? Did someone walk you through the imaging and show you the bone that's there, not just the bone that's missing? Did they show you the nerves, the sinuses, the nose, and other anatomy to avoid? Did you receive a full surgical plan, or did you receive a general impression? Did anyone ask what outcome you were actually trying to achieve, not just what problem currently is? The patients who come in after being turned away almost always describe the same experience. A regular x-ray, a visual exam, a short conversation, and not enough bone conclusion. In a referral to a denture clinic or wait-and-see approach, 5 minutes of conversation, replacing a process that, done correctly, takes considerably longer and requires considerably more technology. Here's what real evaluation covers. First, a cone beam scan that creates a full 3-dimensional map of the jaw, not a flat film. Second, a digital surgical plan that identifies exact implant locations, angulations, and load-bearing zone before anything is touched. Third, a conversation about what the patient actually wants. Fixed teeth, same-day delivery, long-term function, and whether that plan serves that goal. Fourth, an honest account of what's realistic given healing time, bone density, and with systemic health, and without manufacturing obstacles that don't exist. Fifth, a clear step-by-step explanation of the entire process so the patient leaves with full understanding of what happens next. Not a printout of codes they can't decipher. If you didn't receive all 5 of those components, you didn't receive a full candidacy evaluation. You received a first impression. And a first impression from someone who may not specialize in this procedure isn't a verdict. You're obligated to accept once you know what a real evaluation looks like. The next piece is understanding the mechanism that actually determines outcome. Because there's one variable in this entire process that predicts success more reliably than any other, and most patients have never heard it discussed. Here's what closes this. Earlier, I told you that there was something I discovered that changed the entire frame of this conversation. This is it. The variable that determines whether someone is a candidate for permanent full arch implants isn't primarily anatomical, It's procedural. It's about who's doing it, how they're planning it, and whether the process happens in one place with one team that controls every step. My grandfather at 94 is the illustration, but the principle holds across thousands of cases. When the surgery is planned digitally, when the implants are placed by someone who's done this procedure thousands of times, when the teeth are manufactured on site the same day, when there's no handoff to a second provider or a third office or an outside lab that adds weeks to the timeline, the outcome is predictably different. The complexity of the anatomy becomes a surgical problem with a digital solution, not a reason to turn someone away. Stop accepting a candidacy verdict from someone who doesn't perform this procedure as a primary clinical focus. Stop confusing a referral to a denture clinic with a thorough evaluation. Stop assuming that bone loss is the end of the conversation when advanced placement techniques exist specifically to work around it. Start asking one specific question in every consultation. How many full arch cases had you personally completed? Not the practice, not a colleague, the person who would be placing my implants. The answer to that question will tell you more about your candidacy than any x-ray results. We have honest conversations. When I sit here with a 3D image in front of the patient, I will walk them through the anatomy. I'll point out the volumes of easy bone and hard bone. And given the condition and the complexity, I'll say, hey, this is, as easy as it gets for me because there's loads of bone, or, if this is going to push my surgical skill set, we'll have that conversation and say, we can put our faith and trust in me because I've done cases harder than this. But this is all up front with the patient. Understanding the mechanism is powerful, but it only becomes useful when you have something concrete to do with it. The last piece of this is what you can do today before you make any decision to find out where you actually stand. Most patients make decisions about their teeth based on the most recent conversation they had with a dentist. That conversation might have happened years ago. It might have been with someone whose entire implant experience is a weekend course. It might have been with someone who's excellent, who simply doesn't specialize in complex full arch cases. The conversation itself isn't the problem. Treating it as final words is. If a cardiologist told you that you weren't a candidate for a specific procedure, you wouldn't simply accept that and go home. You would seek a second opinion from someone who performs that procedure daily, whose outcome data you could review, whose experience in your specific presentation was deep enough to be meaningful. Teeth are no different. The stakes are different, but the logic is the same. A patient I've seen who spent years living with dentures, or avoiding food, or hiding their smile, or pulling teeth one at a time as each becomes too painful to keep, and who finally walked out one appointment at our office with a permanent fixed set of teeth that they could have had a long time ago. The thing every single one of them says the same: they wish they'd done it sooner. Not because the process was easy or the surgery was nothing, but because the years they spent living in the in-between were the hardest part. Here's what to do tonight. Pull up your most recent dental x-rays if you have them, or ask for a copy from your local dental home. Look at the date. If your most recent imaging is more than 18 months old, write down this question: has anything in my bone density changed since this was taken? And would a 3D cone beam scan give me a more accurate picture? Second, write down exactly how many full arch cases the practitioner who evaluated you has personally completed. If you don't know the number, write down the question. Third, and I want you to highlight this, write this at the top of your page: am I not a candidate, or am I not a candidate for this particular practitioner? Bring those three things to your next consultation. The answers will tell you everything about whether the conversation you had was a real evaluation or a first impression. My grandfather didn't need a different anatomy. He needed a different evaluation from a different practitioner using different technology in a different surgical approach. That's the whole story. And it applies to more patients than the dental industry would prefer to admit. If this changed how you're thinking about your own situation, the next video goes even further, called "You Don't Have a Candidacy Problem, Your Dentist Has a Training Problem." It covers exactly what's happening in the training pipeline that produces so many of these mismatched verdicts, and what you need to look for when you're choosing who to trust with this decision. That video is up next.